Hello, everyone. Welcome to another Wednesday VMR. Sharmin here with the one, the only, the great, the Prof. Rez, the Prof. Rez. How's it going, friend?
I'm doing well. How are you?
Good. Happy New Year Eve,
Happy New
everyone.
Year to all the YouTube people who are going to be watching this, and Happy New Year to anyone currently present who's in another part of the world where New Year has already happened.
May 2026 be better than 2025.
It's
That's
our year,
all we wish for.
Sharmin. It's our year.
Yes, it is. Yes, it is. A big shout out to Yusuf for presenting a case. A big shout out to Jillian and Glenn for scribing and doing teaching points. We're so excited. Yusuf, thanks for presenting a case.
Yeah, I have a sweet 30-minute case, so it's gonna be great.
Wonderful. When Prof. Rez, you know I love learning from you. So do you want to take the first aliquot? All right, Yusuf, Mike's all yours.
Yeah, so you're on a hospital medicine service and you get called for an admission. You open the chart and it's a 24-year-old female, has a history of schizophrenia, asthma, presenting for quote unquote respiratory failure. So you open the chart and you see that you start reading the notes. So the patient presented for shortness of breath and chest pain for 1 day, was given nebulizers, prednisone, but had increased work of breathing in the ER. So the ER team went to that patient, placed her initially on a non-rebreather, but there was no hypoxemia. It was more tachypnea. And they're basically, the patient is unable to speak from the degree of tachypnea. She was ultimately placed on BiPAP, was getting nebulizers throughout, gets a chest X-ray that is normal, an ABG that is normal, and gets admitted to my service. And I'll pause there.
What a start to a case, Yusuf. um, Maybe I'll just make a few comments here because we're going to get much more data. And Charmaine, please feel free to add. One is we're dealing with a young patient. We don't have the past medical history yet, but generally, I'm assuming this is a relatively healthy individual. And then, secondly, we're dealing with an acute process, almost hyperacute. This is just 1 day of tachypnea and shortness of breath. And there's something that's worth highlighting here. There is a difference between shortness of breath and tachypnea and hypoxemia. Actually, all three have something unique that it's worth discussing. Shortness of breath is a subjective symptom. No one can disprove someone having shortness of breath. So if I said I'm short of breath now, it doesn't matter how I look, it doesn't matter what my oxygen is, it doesn't matter what my respiratory rate is. It's subjective. Now we have a disconnect because the patient is extremely dyspneic, but there isn't any objective findings in terms of hypoxemia. Now, hypoxemia is objective finding, and the way we test for that usually is a pulse ox. And when we do the pulse ox, we analyze via different wavelengths of the degree that these hemoglobin molecules are oxygenated. So if someone has a lot of nail polish, or they have cyanosis, or they have scleroderma, that pulse ox might not pick it up. But Yusuf went one step further where he analyzed the actual blood. And in the actual blood, you get the PaO2. So I think we can confidently say, Charmaine, that this patient is not hypoxemic. Now, tachypnea is interesting in that it is an objective finding. You look at someone, you measure their respiratory rate, but unlike hypoxemia, you can't you can't fake hypoxemia. I'm not saying that this patient is faking it by any means. I'm just saying that there is some control in terms of the respiratory rate. So at point blank, if someone tells me they have tachypnea without hypoxemia, I would be wondering if there's another driver for the tachypnea. And to give you a firm example, something like a metabolic acidosis, where you're increasing your respiratory rate to blow out the excess CO2 and generate a respiratory alkalosis to compensate for the metabolic acidosis. So immediately, when I'm looking at the chart as a hospitalist, I would see if a lactate has been sent, if a BMP has been sent, and I'd be very curious to what the patient's pH is. With regard to using BiPAP and non-rebreather for someone who is tachypnic but not hypoxemic, that's a bit puzzling to me, to be honest. Like, obviously, the two common situations where we do use BiPAP is if someone has heart failure with pulmonary edema where the positive pressure pushes out that fluid from the alveoli, or someone has COPD and they're chronically obstructed and this helps them breathe. So I'm looking forward to learning from Meredith the utility to later at the end of the case after we discuss this, the utility to BiPAP in this circumstance. I think asthma in general, we know that this is bronchospasm, that there's difficulty with getting air out. You would expect to see some hypoxemia if this was a severe asthma exacerbation, but it seems like they empirically treated the patient for such. So Sharmin, where I'm at is I'm more interested, honestly, in the tachypnea than the dyspnea. And I'm wondering if there's another driver for the tachypnea, like acidosis or like a panic attack. Now, if this patient is just having a panic attack, the tachypnea leading to the increased respiratory rate and blowing off of CO2 should result in an alkalosis. But if this is a metabolic acidosis leading to a compensatory tachypnea, then we would expect the patient's pH to be slightly low. And I'm going to give the mic to Sharmin, but Yusuf, the pH was normal in this circumstance?
Correct. So initial pH and PCO2 were normal.
Okay, that's really important because the normal pH doesn't rule out the possibility of two processes like a metabolic acidosis and a respiratory alkalosis bringing you somewhere to the middle. But the PCO2 being normal sort of suggests that you're probably not going to have much in terms of a metabolic derangement, especially if the pH is normal. Mic to you, Sharmin.
Oh, I got nothing to add. I love that, Prof. Rez. I totally agree. The thing that caught my eyes more than anything was the increased workup breathing rather than any like the dyspnea or like concerning for hypoxemia. And I totally agree. I think like airway obstruction is the one that we often think about with her history of asthma. With like asthma exacerbation, like in a young person, sometimes if they're too tight, initial ABGs might look okay, but they can tire out. So I think that's something that I would keep watching and repeating the gases for her just to make sure, we are not at the brink of like her tiring out and becoming more hypercarbic. The fact that her like PCO2 is normal if she has really increased workup breathing, I'm just like, oh, I would have expected her to be able to blow off more. But yeah, I think like she has that risk factor. But I totally agree with you. I was like, oh, I wonder like if she has any like acid-base status, like any BMP abnormalities that would explain her increase of workup bleeding. The other two things that I often think about, a couple of things that I often think about are like any like chest wall, like mechanical issues that would increase workup breathing or neuromuscular weaknesses and like abdominal as well. Like if people have a lot of ascites, any abdominal issues that is just like causing some pressure on the chest wall, that could potentially do it as well. But yeah, I'm like very curious to see where this goes. I mean, I can only imagine like 24-year history of asthma coming to the ED with dyspnea. I think like the whole diagnostic momentum for asthma exacerbation, it's really, really, uh, acute, for a lack of a better word. But I'm curious to see what we find out more.
Yeah. So speaking of acuity, so I'm reviewing the chart, and the nurse calls me to just come to bedside, and I go to the bedside and I walk in the room. The patient is like sitting forward and is like taking rapid breaths, like very rapidly. She has family at bedside. Her heart rate is fast. She's like her heart rate was like close to like 130, 140. She's on a BiPAP, and the tidal volumes were very high. So tidal volumes were like more than like 600, if I remember correctly. You when you're walking in the room, you're standing at the edge of the bed, you hear like an audible wheezing or like a sound, but then I auscultate her lungs and I don't hear like wheezing when I hear it, but it's like audible to the ear, but I put it on the lungs and I don't hear like any wheezing coming from the lungs. Uh, you had reviewed the labs. The BMP was essentially normal. CBC was normal. Her only home meds were aripiprazole for like schizophrenia, like monthly, long acting, and albuterol PRN. And the family is at Bedside. They said that she's run out of her inhalers. And I'll just pause there.
All right. Wow. There's nothing like being at the bedside with you yourself. So yeah, I think like I'll focus on I mean the exam like respiratory rate elevated. We were just kind of getting the sense of that with the increased work of breathing that Yusuf had told us about. I think like the part that was like very interesting is like the audible wheezing, but when you like then when you were auscultating, you're not hearing any wheezes. So that often makes me think about like your upper airway versus lower airway. So the things that I would worry about if like I'm hearing like something like a stridor or audible wheezes, are they like angioedema, anaphylaxis? She got some steroids, but any reason for her to have those? Especially like angioedema, like we don't hear any like rashes, like her blood pressure is fine, so like probably less likely for this to be anaphylaxis. And then like any reasons for like laryngeal edema, oftentimes you will see that like post intubation, like extubation if someone's been intubated for a long time. Any like aspiration, epiglottitis, it's sometimes vocal cord dysfunctions can do it. So I would like want to be able to investigate those a little bit more. Definitely take a look in her mouth, making sure she doesn't have any angioedema there. Sometimes in case of asthma exacerbation, if people are like very tired and tiring out, they're just like not moving air well enough for you to appreciate wheezing. So this again, like just given that history, running out of inhaler, you just gotta have to be careful with asthma. And I think at this moment, I would just keep treating her for an asthma exacerbation in addition to making sure I'm not missing anything else, especially like upper airway. Sometimes like if people can mucus plug pretty bad as well if they have really bad parenchymal disease, and that can cause a lot of distress. I would assume in someone like her we would see hypoxemia. Um, but that's where my mind went to. Prof Res, anything to add?
I just want to say you're such a sharp shooter. Like to be able to say, hey, I'm worried about an upper airway obstruction is just beautiful. And just to emphasize that point for some folks that may not know this, if you think about like COPD, asthma, and you're having bronchospasms down distal airway of the smooth muscles, you're not having any issue of taking air in, right? So you're not going to really hear anything. But if Yusuf is able to hear wheezing on inspiration, that tells you there's an issue with the upper airway because it's on inspiration. And so probably, and people can mistaken, and I've done this before, stridor for wheezing. But Sharmin, what this becomes for me is stridor, and it becomes an issue of a central airway obstruction. And I think like I'm working quickly to know, is there something intraluminal or something extraluminal? And I would get ENT to see this patient stat to do a scope. And someone who's 24 with no significant past medical history, unlike our veterans where we would think about some kind of cancer that's brewing and finally tip the patient over, I would worry about like paradoxical vocal cord movement or something of that nature. So I think now I'm just like tapping into my diagnostic armamentarium, and one would be like just visual inspection by ENT. The second would be cross-sectional imaging, not of the chest where we think the problem is, but of the neck. You would get the chest too. But for me, the frame has changed from asthma and like we're avoiding the diagnostic momentum to just upper airway obstruction in a young patient based on the inspiratory sounds that Yusuf, and then diagnostic armamentarium is cross-sectional imaging is going to be very helpful of the neck, but as important is ENT quickly looking into the oral pharynx to evaluate the vocal cords and the upper airways.
Awesome. This aliquot is more about like management reasoning more than diagnosis. So we were also like really worried, like could she have like an anxiety component, is having an anxiety attack on top of whatever is going on. We do end up continuing the nebulizers, giving her like IV Ativan on the spot. Her VBGs have like her CO2 is going down slightly from all the like increased work of breathing, but her pH is okay. Her SATs are okay throughout. And then like maybe 4 nurses run in the room and they're like, okay, this patient needs to be intubated. And I'm standing there like, okay, no, let's calm down. And they run, grab the ER people, and the ER people are in the room and they want to intubate. And I'm like, okay, let's just wait. Like, let me call to the MICU team and like let the MICU team evaluate. But I'm just wondering, how would you deal with that situation and if you've faced it before?
I totally understand the concerns of everyone because this is a young person. They look like they're at the brink of respiratory failure, even though the pulse ox is not reflecting that. I think the CO2 going down now with this increased work of breathing and probably them developing somewhat of an alkalosis argues against lower airway bronchospasm and retention of CO2 and further makes me worried about the upper airway. So I would tell the staff, look, we're going to get an ENT. I'll try to, it would be totally appropriate to activate a rapid response, but the quicker you can get ENT to the bedside, the better, because they'll be able to look into the oral pharynx and either provide reassurance for everyone or raise concern, meaning they might find something that hints to the cause of the patient's audible wheezing, which may be stridor. And by the way, Yusuf, if you haven't done this, I would put the stethoscope right over the trachea to better understand, and then I would time it to see if this sound is happening with inspiration, which would further confirm upper airway obstruction. But I'll pass the mic to Sharmin. For me, it's just understanding the nurse's concerns and knowing the 2 things I want to evaluate. Stat is just looking into the throat. I'm less concerned for the lower airways, and then potentially cross-sectional imaging of the neck.
Yeah, I totally agree. It's a really tough situation to be in. And I think like, yes, the intention of like wanting to make sure the airway remains secure is in a 24-year-old. It's, I think that's what kind of like is drives a lot of like ED is also like stabilization, triaging, and then we have time to figure out what is going on. So I understand that impulse. I think like couple of things that I would like watch out for. If she's like drooling, like having a hard time, and you look at the mouth and it's like very edematous, then I can understand you're like, oh, if you're really worried about impending collapse, like the patient needs. But I think like I totally agree. You might need ENT for this intubation anyway. So like getting them to the bedside is going to be really, really helpful. And then I think like if there's like any hoarseness, sometimes like vocal cord pathologies can be like worse like with anxiety. So I think like trying to have her calm down, it seems very fair too. But yeah, like I totally agree with what you guys are doing and what Prof. Rez said.
All right, awesome. So at this point, there are like maybe 15 people in the room, and they're like getting ready to intubate. But then I call the MICU, and Dr. Greer walks into the room. She's like, "Everybody, calm down. We're not gonna intubate. Let's let's wait and see. Let's give some medication and let's calm down, and we can give it some time." And I'll give her some space to talk about that in the end as well. So the patient ends up going to the MICU, getting gets a lot of anxiolytics, so she gets like Presidex and eventually ketamine as well. And then there was this discord between the rate of the tidal volume that was being on the BiPAP and the degree of respiratory rate. And then on the labs, the RSV comes back positive, and then they do end up getting a CT of the chest and a CT of the neck. So a CT of the chest just shows bronchial thickening, which can be seen in the setting of asthma, and then a CT of the neck shows prominent tonsils and nasopharyngeal adenoid tissue. And the next aliquot will basically tell you the case closure.
Ah, Dr. Gear to the rescue. Love it. Um, so I, yeah, I think like kudos to you all getting the right people involved in the right time. And I think sounds like RSV came back positive. Right. So, like, I think like a viral syndrome on top of someone who already has like asthma, and I think like the prominent tissues there, I'm curious to know like if that is something that, in addition to like a viral syndrome, has gotten worse and she has like more edema there, hence like the striders that we're appreciating. And on top of that, that is like causing a lot of like anxiety for the patient. So that is like where my mind went into with like kind of the thickening and the excess tissue, whether there's like additional edema and and perhaps like she has some chronic issue there to begin with. Prof. Russ, what are your thoughts?
I'm right there with you. And I think the cross-sectional imaging is enough to explain like the upper airway stuff. And of course, this can also trigger bronchospasm in someone with a history of asthma. So at this point, I'd try to give dexamethasone. I know we gave prednisone, but I'd give dexamethasone just to decrease the swelling. And then I would ask for the opinion of Dr. Greer as to what should be the next steps in this patient. But it sounds very compatible with RSV, a lot of inflammation. And if the pulmonologist, the radiologist think that's enough to cause the upper airway obstruction, then the focus becomes how do we decrease the swelling? We can't treat, I don't think there's antivirals for RSV, or if there is, I'm not sure how effective they are. But yeah, I think what's in our arsenal now is dexamethasone to try to decrease edema in the oral pharyngeal space.
Yeah, that's great. So, like you were mentioning earlier, the team ends up calling ENT. ENT does do a scope. They say there's normal like vocal cord mobility there, and there's like no evidence of subglottic stenosis. The patient ended up doing better the next day and was discharged 2 days later and was never intubated. And then I'll give the mic to Dr. Meredith Greer. She's a pulmonologist here. She's also board certified in critical care, does sleep medicine, and is one of the smartest people I know, but is also one of the best educators I know. So Meredith, the floor is yours.
Hello. Thank you for having me last minute here. I do remember this case. I had actually like two of these, I think, that week that were very similar, or three even, young women that I was able to avoid intubating. So I think I think was one of the most pertinent teaching points here was that despite everybody's anxiety and distress and this great differential about all these things and these vitals that you've highlighted in red and whatnot, the person did not need intubation. So I think before we talk about kind of the asthma mimics and what we thought about this case, I think talking about when you guys say we want a secure airway, what does that mean? So I think you brought up like there's not a lot of saliva or oral secretions, which is the point, right? Because if she's able to protect her own airway from aspiration, then she does not need a ET tube, right? Yusuf, you had mentioned she was getting volumes of like 600 at one point. I don't think that was consistent, but like that means that something was able to get past any obstruction, enough to where I don't think you need to rush to intubate this person. And I think when you have a more flexible upper airway obstruction, like redundant tissue and adenoids and things like that, I think you were asking how is BiPAP helpful in this situation? It's because it pushes it out of the way, right? So I like to talk about not obstructive sleep apnea, but obstructive awake apnea, sort of. So you can hear, in patients who may be overweight or have large tonsils, especially in kids. I do peds to adult transition as well. And big tonsils is like the number one cause of sleep apnea, but you hear kids having sort of noisy breathing. Noisy breathing is what we call upper airway breathing. It's not a stridor and it's not a wheeze. It's just an increased turbulence because of a change in the lumen that the air is going through. And so PAP therapy is great for that, whether you're awake or you're asleep. So I think that's super important. And I think knowing when you're in the ED, especially working with your ED colleagues to basically provide moderate sedation, like they're comfortable with for procedures, like when they do, like put your shoulder back in place and stuff like that. Like the ED does ton of procedures with sedation where they don't intubate the patient. So kind of like working with them to be like, hey, like remember how you guys are super comfortable with ketamine all the time? Like let's do that for this. And so like I'll monitor the airway. We have everything set up. If we need to put the tube in, we can, but like let's try this. So I think a lot of times we jump to intubate patients with asthma and COPD. They can really, really benefit from like Ativan, morphine, ketamine, that kind of stuff. One note on ketamine, and then I'll talk about airway stuff, is that ketamine is a bronchodilator. Propofol is actually a bronchodilator as well. They're both vaguely mediated bronchodilators. And so propofol and ketamine, for that reason, are our sedatives of choice in patients who are having airway issues. Propofol, you're not going to give to somebody who's awake, so you're going to do ketamine for those people. The one downside of ketamine as compared to propofol in these scenarios is that bronchorrhea is a side effect of ketamine. And so that sometimes can cause more issues, but I think it's always worth a try because it's such an easy, non-respiratory suppressing, non-blood pressure suppressing medication that all emergency medicine and critical care doctors are like comfortable with. And so I think that's a good one to use. And then if you end up having to intubate, great, you already have ketamine, right? And you do RSI with ketamine as well. So I think that was one of the most important things. And then I think you guys asked like why BiPAP? I think it was for the work of breathing. So the biggest thing that stood out to me when I went down to this room was that the oxygen was fine. The CO2 was fine. So like, what do you mean asthma exacerbation? I'm not saying that this person does not have a history of asthma and that they don't have RSV and they don't have a component of their asthma acting up a little bit here, but this was just not a person who was on the verge of like needing to go for inhaled anesthetics in the OR, needing to get ECMO, right? Like those people that we usually really, really worry about needing to get paralyzed once they're intubated. That those people have problems with their oxygen and their CO2, and this person did not. So I think when I first went and saw this person, to me, it looked like vocal cord dysfunction straight away. She does have a history of schizophrenia. And so I think that was really important to her sort of risk for maybe a heightened anxiety, especially in the Grady ER with 14 doctors around her. Um, and she has real, like, non-supratentorial things going on for her, like the history of asthma, the RSV. She has enlarged tonsils and adenoids. So I think it was sort of a perfect storm of like the RSV triggered some of this inflammation. And then once she felt like she was a little bit more short of breath, or more likely she felt overburdened by like the secretions that were probably happening from the RSV, then I think it sent her into sort of like a panic state that led to this vocal cord dysfunction. And I think it was really hard for her to calm down because once that happens, you really do have basically inducible laryngeal obstruction. So you are hearing stridor because the vocal cords are coming together when they shouldn't be, right? And so whether or not it starts from a more of like an anxiety type of thing, usually precipitated by also a physical thing, it then becomes more physical. Does that make sense? And so I think that physically treating it, like separating your vocal cords by using PAP, right, is super helpful in this scenario. And then also addressing any sort of anxiety is going to be helpful as well. We know that patients with COPD have like higher levels of anxiety than patients their same demographics without COPD because feeling like you can't get a breath is incredibly anxiety provoking. And so it's not surprising that somebody in this scenario would end up having sort of this inducible laryngeal obstruction, which is just kind of like another term that I think helps better understand vocal cord dysfunction. So I totally agree with you guys about like wanting to get a scan and wanting to get a scope, but in no way are you going to do that in somebody who's breathing 40 times a minute. So I think for us, we really had to make sure we could sort of calm the whole situation down, calm down the work of breathing, work on that slowly. And we actually had her sleep overnight on BiPAP. And I think we ended up perhaps starting a Precedex drip once she got to the unit, because a lot of times we'll do that if we can calm you down with some Ativan and some ketamine in the ED. Then when we bring you up, we can put you on a Precedex drip, and that again doesn't suppress your respiratory drive, and it just sort of helps calm you down a little bit to be able to also tolerate BiPAP because it's not the most comfortable thing in the world. And then in the morning when she was feeling better, then we were able to have ENT come. The other huge thing that I did was I got her partner with me at the bedside. So he was like outside of the room, she was alone, and I felt like that was not helpful. And so this is true for anybody, not just somebody that might have anxiety, but like I brought him and he helped me talk to her about how we were helping her breathe and she didn't need to breathe on her own anymore because the BiPAP was going to sort of take over for her. So I could go on all day about BiPAP settings and how we did it, but I think what is going to be more helpful for y'all is just to do a real quick rundown of mimics of asthma. And so I sort of think my brain always does inflammatory versus not inflammatory. So in the inflammatory versus not, you break inflammatory down to infectious versus not. So if you have infection, that could be like a respiratory bronchiolitis, which is probably what this person had, right, from the RSV, or an epiglottitis. So you don't want to forget about that. Epiglottitis is like a huge cause of stridor, especially in pediatrics, but this is a young woman, so it could be seen in her. And you can just get like a neck x-ray actually from the side to see the thumbprint sign for epiglottitis. And so I think that is something to consider. Some things that are inflammatory but not infectious. So any type of autoimmune condition, so Sjogren syndrome can be associated with follicular bronchiolitis, and rheumatoid arthritis can be associated with constrictive bronchiolitis, which you can see like air trapping with on PFTs and also CT. Those aren't going to be like acute same day, but similar to this patient, they could have something underlying and then get an infection and have an exacerbation of it. Also vasculitis, so EGPA or Church-Strauss. So that one is like really, really something you got to keep in your back pocket when people say like, hey, this person has asthma and it's not getting better. Like, what do you want to think about? You always want to think about that. So you want to check their eosinophils. And then hypersensitivity pneumonitis. So that's another typically considered like a interstitial lung disease, but it is airways based because you're inhaling and having a reaction to an allergen. And so I think those things should all be considered. And you can get inspiratory and expiratory CT scan to look for that air trapping. And then from a not inflammatory standpoint, I usually break that up into malignant or not malignant. And so from the malignant side of things, you would think of like you guys did, is there like something in the airway, right? And so any tumor can be in the airway, but I would say that carcinoid is probably not a common tumor, but the most common when we think about airway malignancy, especially when you think about presenting with asthma. I just had a patient in clinic the other day who was like, I'm 45 and I never had asthma, even as a kid. And now all of a sudden people are telling me I have asthma. What's going on with that? And I was like, this is going to be carcinoid. And it was carcinoid. So just because things don't happen all the time doesn't mean that you won't see it eventually. Or as one of our ILD attendings says, it's not that you haven't seen it, it's that you saw it and you missed it. So don't be that person. Keep these things that you learned on step one on your differential. So that's something I would definitely think about. And if you didn't see something in the upper airway and you were worried, then you would want to go ahead and do a full bronchoscopy and look through the airways. But a lot of times you can see it on CT scan as well. And then last, out of not inflammatory, not malignant, that's where things like anatomic and metabolic, psychiatric, vascular, all that stuff comes in. So that's sort of where I put the vocal cord dysfunction and the inducible laryngeal obstruction. And then there's some other more rare things like tracheal, like fistula type things and stuff like that. And tracheal diverticulum, which I think is like way, well, it's not rare, but it's rare to cause a problem. So it's not something I think would lead to this. So that's sort of like what I had. And then just a couple other notes that I had was it's really important to know the difference between tachypnea and hyperventilation because hyper and hypoventilation are technically defined by the CO2. So you're not hyperventilating unless your CO2 is below 35 and you're not hypoventilating unless it's above 45. right? So you're either having low or high rate or low or high volume or both. And so I think although there were periods where we could get her sort of calm and talking to her where she could take in large breaths, I think a majority of the time when she was feeling super anxious and her vocal cords were closing against her will, like I don't think she was actually getting a good enough volume to make an appropriate minute ventilation to blow off the CO2 that she was creating. So don't forget about that because work of breathing is work, right? Work is force times distance. That's measured in joules, converts to kilocalories. It's work. So it's going to produce CO2 and it's going to produce lactate. So a lot of times these people like are going to have like trouble getting rid of their CO2 because they're just continually producing it. And also sometimes they'll have a lactate from the literal work of breathing. Um, so I think that's kind of like my main takeaways. And as a sleep doctor, I'll just give a plug that this patient absolutely needs a sleep study. Because how could we prevent this going forward is one, she might end up needing a tonsillectomy, adenoidectomy, if she's this high risk and her upper airway is this easy to irritate, even with a virus. I shudder to think what would happen if she got strep. Um, but two, just benefiting from CPAP. We know patients with asthma have better control if they are concomitant sleep apnea is treated with CPAP at night. And so that may help prevent her from getting into one of these situations again. So I think those were all my thoughts on this patient.
Oh, absolutely brilliant. That was a masterclass. Thank you so much, Meredith. We really appreciate you being here. I love the asthma mimics differential diagnosis and the point about like walking us through the case and the vocal cord dysfunction, the use of BiPAP, just absolutely 10 out of 10. No notes. Thank you so, so much for being here. Do you have anything else that you wanted to share?
No, I think similar to all the teaching points about the asthma mimics and the diagnostic momentum about intubation. And I love getting the expert there whenever somebody wants to do something like intubation. So, Prof. Rez, any reflections?
No, Meredith, that was like incredible. The knowledge that you shared with us, also distinguishing between tachypnea and ventilation. And yeah, that was really, really nice. A nice review. And it's so nice to see you again. I thought your name was familiar. Then I texted Robbie and he said, yeah, you presented both as a resident and as a fellow. So now it's all coming back to me. Nice to see you as an attending.
Yeah, thank you. I think I presented as a resident. I definitely presented as a fellow. I might have presented as both a Palm Crypt fellow and a sleep fellow. I was just a fellow for a very long time. But yes, happy to
Just
come back
gaining
as an
all the
attending.
expertise.
Oh,
Um,
and then just one quick question, if I may ask Charmin. Meredith, I remember I had a case at Hopkins, and basically for the vocal cord dysfunction, don't you have to diagnose it at the moment it's happening? Meaning that the next day when they look and everything was fine, it doesn't disprove the fact that that might have occurred?
Yeah, it's really hard in my experience to diagnose it on scope because, like, it's rare that you're going to get a person who's in that heightened catecholamine state, basically, right? To be able to tolerate the scope without feeling like a horrible person, probably, you know? I mean, and also just they might not even tolerate it at all. So I think that is really hard because, like, a lot of it has to do with how they're breathing, right? And how they're sort of like pulling really hard a lot of times for the breath, which is going to like make your cords more likely to go closer together and stuff like that. And when we do scopes, we were telling people to breathe calm, right? Like breathe through your nose so the flow is laminar versus when you breathe through your mouth when you're anxious, like it becomes all more turbulent and stuff like that. And so, yeah, I feel like just because you get a scope that says during the scope there's no vocal cord dysfunction, to me does not demonstrate that there is not. Also, this patient, if I remember correctly, on the scope had like somewhat swollen and irritated vocal cords. And that could be in part from the RSV, from like coughing, that kind of stuff, but also it could be from the act of like this patient trying to breathe through the cords, not sort of like working how they should in that moment. And so, yeah, I think for me, the biggest thing that I'm trying to teach people when I talk about things like vocal cord dysfunction, It's similar to IBS. It's like just because you think this problem might have originated sort of supratentorially, it does not mean that the patient is not having a physical manifestation of it. I think it's so important, especially in internal medicine, to acknowledge that like both of these things are coming together to sort of make the end product of what's happening. And so, like, the best way to address that is to sort of manage both uh, any of the anxiety or underlying feelings, but also the physical manifestation. And to just like believe the patient and not deny them what they're really feeling, I feel goes like a very long way. And I think talking it through with the patient and also having her partner there. And then after the next day, we also like did a whole bunch of education with her because we wanted her to understand it, understand why it happens, what's the actual physical thing that's happening when it happens, how she can like prevent it, at home. And so I think that whole like counseling part is super important for any patient who has a similar condition.
That's so helpful. So it seems, first of all, I'm reminded when we're doing these simulated cases, like we're not seeing the patient. Here I am talking about CT of the neck and a scope, but you're bringing it to life to try to remember it, like what is actual practical. But it seems like the main thing for this patient was just controlling the anxiety, which may have helped with the and prevented the intubation. Is that fair to say?
I think controlling the anxiety, but also like we did a lot of adjusting the BiPAP settings to her, like, and to we kind of call it overdrive pacing, how you do with refractory VTAC, but I like overdrive PAP people. So I'm like, the thing's breathing for you. I'm taking it over. And so a lot of my sedation that I'm doing is actually so that the patient doesn't try to breathe on their own so much so that they allow them to take that over. And then that decreases the work of breathing. And then when you decrease the work of breathing, they don't have the turbulence, right? And so then when you reduce all of that, then you're more likely to have your vocal cords like go back to their apposition as they should.
Thank you so much. That's all I had. That was really, really educational for someone who doesn't really practice in that space. Thank you.
Absolutely. Thank you so, so, so much, Meredith. We deeply appreciate this being the last medicine thing you do before New Year's. Yusuf, thank you so much for making this happen. This was so awesome. Prof. Rez, always a pleasure. Glenn, thank you for scribing. And Jillian, to you for teaching points.
Well, we've got a lot of teaching already, but so I'll try to be quick. But we had a young woman with a history of asthma presenting with respiratory distress with no like objective evidence of hypoxemia. So we started by discussing the distinction between tachypnea among tachypnea, dyspnea, hypoxia or hypoxemia, and we learned that tachypnea and dyspnea is purely subjective, whereas hypoxia and hypoxemia are both objective findings. And then tachypnea is also objective, but it can be influenced by a number of other things other than just ability to get oxygen in. So then we went on to discuss the causes of tachypnea other than hypoxia. So you can have a metabolic acidosis or a panic attack, so anxiety. But those things you would expect to see on the blood gas. You would either expect to see an acidosis or an alkalosis in the case of anxiety. So those things were made slightly less likely by the normal ABG in this case. And then we heard audible wheezing, but not in the lungs. So that made us talk about the causes of upper airway obstruction. So we talked about angioedema, anaphylaxis, laryngeal edema, or even just fatigue and not getting good air in during a serious asthma exacerbation. And talked about the evaluation of that being sort of a visual exam, ENT, and cross-sectional imaging of the neck. In the end, this patient ended up having a viral syndrome, in addition to possible anxiety, making her have difficulty breathing, and then sort of we think that the fast breathing might make her have more of this inducible laryngeal obstruction. And that one of the biggest parts of taking care of this patient was making sure to manage the anxiety, give education about making sure that she knows she's getting breathing in, and that sort of calms down the whole cycle and helped her to be able to calm down, breathe better, and eventually be more stable. And then we learned a lot about asthma mimics as well, but I left that for Dr. Greer to say.
Thank
Oh,
you so much.
thank you so much, Diane. That was brilliant. Thank you so, so much, everyone. Happy New Year again. Go forth and celebrate. See you later. Bye.